Hi, I'm Jason Howland, and welcome to Speaking of Health, a place where you can learn how to live a longer and healthier life. Our topic today is It's All in the Knees, and joining us today is Dr. Stephen Berthelsen, a board-certified orthopedic surgeon at Fairmont Medical Center, and one of his patients, Betty Hiller. Thank you both for joining us.
It's a pleasure to be here.
Well, Dr. Berthelsen, before we get into what you need to know about knees, let's talk real quick about orthopedics. For folks that don't know, what do orthopedic specialists deal with?
Orthopedics has to do with the care and repair of your bones and joints and muscles, tendons in your arms and legs. Go all the way from your neck to your toes. Some orthopedists take care of spine, and some don't. I don't happen to.
So if you have, so often we hear about sports injuries and ACL surgeries and those kind of things. That's something that you would do, right?
Absolutely. Yeah, those are kind of things that are involving the joints or the tendons and ligaments around the joints and the muscles and the fractures. Those are kind of things we do. Rotator cuff surgery, for instance, carpal tunnel surgery. Those are just some of the things that more commonly people would understand.
So are patients referred to you by their family physician, or can they come to you directly? How does that work?
Both. Many of my patients are referred by other physicians, but a lot of them come in by word of mouth too. They have a family or friend who are taken care of by myself or one of the other orthopedists there, and they say, well, I thought I'd come and see you.
Well, our topic today is It's All in the Knees, and the knees, that's something that you deal with quite often, right?
That's right. It's one of the more common things that we take care of. It's a major joint in the lower extremity that takes a lot of beating, a lot of abuse, and its anatomy is such that it's a little more susceptible to injury than some of the other joints.
Well, speaking of injury, Betty joins us, and you had an injured knee, and you came to Dr. Berthelsen. Tell us a little bit about your story.
Well, on October 2nd, I finally went, and I had my surgery. Before that, I had fallen maybe a few months to a year before, and it gradually got worse.
So you were dealing with pain, and then...
Oh, yes, very much so.
What kind of symptoms did you have?
Well, it got to the point where sometimes when I'd step on it, I felt like I was going to go down. And then it always hurt when I walked on it. And sometimes when I was in bed, it would hurt depending on how I turned my leg. Otherwise, it was time to go to the doctor and see what's causing it.
So when Dr. Berthelsen told you that knee replacement surgery would be the best thing for you, what did you think about that?
I knew I had to have something done, and I thought, okay, let's do it.
Talk a little bit about Betty's surgery, Dr. Berthelsen. This was a partial knee replacement, right?
Correct. And she had a finding which isn't really very common, but is not uncommon either. And she had an area of sort of microfracture in her knee, which resulted in some bone death in the knee called avascular necrosis. So there was an area on the one side of her knee, or sort of the inside of her knee, that kind of collapsed, and every time she put weight on it, it caused a lot of pain. So the only way to take care of that would be to replace that segment of bone. And so for her age and for her status and health, it just worked out that a partial knee replacement was going to do that the best of anything else that would get her going more rapidly than just about anything else we could do. So it worked out perfectly for her.
Now, when you say replacement surgery, you're actually replacing the knee with metal parts, man-made parts, is that right?
Yes. She is now a bionic woman. We replaced just the inner half of the knee. And there's a little skid plate on the bottom that's flat, and then there's a round one on the top, and we take out the joint surfaces and glue those in or cement them in, and then there's a little special heavy-duty plastic button that has a concave surface on one side and a flat surface on the other, and it pops in there, and that's the joint, and that has a way of moving that gives a very natural feel to it.
And Betty, how does your knee feel after the surgery?
It feels like nothing has had to be like normal. Like really, it's just
I
great.
didn't care to say that, by the way, but thank you.
It does. It's really, I'm real happy over it.
Good.
And you had to use a walker up until the part of that surgery.
Yeah, I did. It was safest if I did, because maybe I would fall if I didn't.
One of the things that convinced me that she really needed to have something done was that every time she came in, she really looked like she was in pain. Her face just told us that, I'm hurting.
Partial and full knee replacement, you do both. What's the difference between the two?
Well, first of all, the difference is that the partial knee replacement, as I mentioned, is just one half of the knee, whereas so it's just narrow. A full knee replacement is wide enough to go across the whole span of the knee, all the way from the inside to the outside of the knee. And that gives us the ability to replace all of the cartilage surfaces in the knee. And so that is the the basic mechanical difference. Both do very well. Both last for a long period of time. The advantages of the partial knee replacement is it's a much smaller surgery. Patients get better faster. And not only that, but because we save all the ligaments on the knee with a partial knee replacement, they feel more normal. And like she says, it feels like nothing happened. For a lot of people who have this done, that's the way it feels. It feels natural.
How soon, Betty, did the knee start feeling good after surgery?
Well, when I had to get up out of the bed, even at the hospital, it felt better.
You could tell that soon,
Yeah,
even.
I could. And as time went on, it just got better and better. And I did my exercises, and I realized that was important.
And that's probably something that's key, right, Dr. Berthelsen, is physical therapy is key for patients.
Yeah, patient motivation, patient involvement is really important, because I can do the surgery, but I can't make a move. And they have to have the understanding and desire that it's really important that they get this knee moving, because otherwise they're not going to be as happy with the knee if they don't move it and they end up with stiffness or limited motion. So yes.
It hurts at first, though, when you start
Yes, it does.
therapy while you're still in the hospital.
It's
but you just have to do it.
Counterintuitive to move that knee when it hurts so much. You think, no, I need to protect this, but that's just the opposite.
Yeah.
You need to move it.
So what kind of physical therapy, what kind of exercises do you have to do, Betty? And you're still doing, right?
Yes, I am. You have to lay down, and then you pull your foot up and hold it count to 5, and do it about 20 times. And then you put I have a 3-pound coffee can, and I put a bath towel over, and I put that under there, and then I do that 20 times. And then I sit up, and then I sit on the edge of the bed or wherever I am, and do that, raise it up 20 times.
So the key is motion and also building up the muscles, keeping the muscles busy. Is that right?
You lose muscle mass very quickly after any kind of injury where you don't use it. And it takes a lot longer to get it back than it took to get rid of it or to lose it. So, yes, building strength is important, building motion is important.
Well, with Betty's case, it was an injury that led to her surgery. Often you see osteoarthritis as being the case. Talk a little bit about what osteoarthritis is.
Osteoarthritis is basically a deterioration of the joint. There are probably multiple causes for it, and some of the reasons are the hereditary. Sometimes some families, my mother had bad knees, or my uncle had bad knees, and my sister has 2 knees replaced. And so you hear this very often, that it tends to run in families. Sometimes the way a person's anatomy is, they wear out one side of the joint because they're maybe a little bow-legged or a little knock-kneed. And so those things can affect injuries also. Ligament injuries can cause problems. But it's basically a wear and tear in the joint that excessively traumatizes the knee in a progressive, day-by-day basis, so that eventually the joint collapses down. All the cartilage surfaces go down to its bone to bone, and the bones are not meant to rub on each other, and it hurts when they do. And it causes catching and popping and snapping and pain and swelling and all of the things that you might expect from arthritis.
So surgery is a viable option then for folks that have that?
Before knee replacements came along, a lot of people ended up walking with canes or sitting in wheelchairs and not walking very much at all. And so, but knee replacement has given a lot of people a new lease on life. They are able to get around, able to move, to have fairly normal lifestyle. And for many people, it's better lifestyle than they've had in years because this pain has been gradually diminishing their activity level until they have this knee replaced. So yes, it has been a great benefit for many people. In fact, about 500,000 knees are replaced every year in the United States alone.
Oh my.
That's a lot.
And it sounds like that was the case with you, Betty, that your life improved dramatically.
Oh my,
afterwards.
yes. It certainly did. Be more self-sufficient. Get around without pain.
What about prevention, Dr. Berthelsen? Osteoarthritis, you talk about how it a lot of times is hereditary. What can you do to prevent maybe the effects starting early?
I think staying active is important. Sometimes there's a balance, though, because if you do the wrong kind of activity, you can aggravate your knee. For instance, if you jog, you put a lot of impact on that knee, whereas if you walk, you can get good exercise, just about as good, but without all the impact. So you're less likely to stir up the arthritis in your knee or to injure your knee. Other things you can do are weight control. I don't think being overweight causes arthritis, but it certainly aggravates it and hastens the time to when you might have to have your knee replaced. So staying fit, having good weight control, and then smoking. Smoking is hard on your tissues and all over your body, and so it decreases the circulation and the nutrients to all of your body. So I think that has an effect on it.
See, normally you wouldn't think smoking, you hear it so much with lungs and heart and that kind of thing, but it affects your bones and joints too.
Yes, it does.
So let's go back real quick to partial knee replacement surgery. This isn't an option for every patient, right?
That's correct. In fact, only about 10 to 20% of all the knees that need to be replaced will qualify or be appropriate for a partial knee replacement. And it works great, and there's a lot of good results for it, but it's not for everybody.
And how do you determine if that person is ready for the partial knee replacement and not a total knee replacement?
There's a particular pattern that we see on the x-ray that tells us we need to know that the ligaments are intact. We need to know that there's only arthritis on one side of the knee, and sometimes we take special x-rays to determine that.
All right. Well, unfortunately, we're all out of time, but a great discussion. We want to thank Dr. Stephen Berthelsen, board-certified orthopedic surgeon at Fairmont Medical Center, and his patient, Betty Hiller, for joining us today on Speaking of Health. Thanks for joining us.
Thank you.
Have a great day, everybody, and be healthy.